Good morning. My name is Jeeva Jose, Nursing Tutor, Department of Child Health Nursing, Sri Balaji College of Nursing, Bharat Institute of Higher Education and Research, Chennai. My course name is Genetics, course code 610. Topic is genetic testing. So, let us see what is genetics testing. So, today I am going to teach about the genetic testing. So first we will see the introduction of genetic testing. So these are in these topics we are going to discuss about the definition of genetic testing, purpose of genetic testing, types of genetic testing, basics of genetic testing, prenatal diagnosis and screening, common diagnostic treatment, techniques for pathological examination, ethical, legal and psychosocial issues in genetic testing. Okay, so see, these all are the things we are going to discuss for today's our class. So first we will see the definition of genetic testing. Genetic testing is defined as examining a sample of blood or other body fluids or tissue for biochemical, chromosomal or genetic markers that indicate the presence or absence of genetic disease. A genetic testing is analyzing a DNA to look for genetic alteration that may indicate an increased risk for developing a specific disease or disorder. Otherwise, it is also defined as type of medical test identifies changes in chromosomes, genes or proteins. Okay. This is the definition of genetic testing. So what are the purpose of genetic testing means? Confirmational diagnosis of a symptomatic individual, forensic or identified testing, pre-symptomatic testing for predicting adult onset disorders such as Huntington's chorea. It allows the genetic disorders of vulnerabilities to inherited diseases. It can be used to determine a child protein person sensitivity. These all are the purpose of genetic testing. Then, what are the reasons? What are the reasons we should do the patient with genetic testing? Finding genetic diseases in unborn child. Finding out if people carries genes for a disease and might pass it on to their children. Screening embryos for disease. Testing for genetic disease in adult before they cause symptoms. Making a diagnosis in a person who has disease symptoms. Figuring out the type or dose of a medicine that is best for a certain person. These all are the reasons we are doing the genetic testing. The types of genetic testing. What are the types we are using for genetic testing and basics of genetic testing? Quantitative genetic research has built a strong case for the importance of genetic factors in many complex behavioral disorder and dementia in the domains of psychopathology, personality, and cognitive abilities. The genetic basis of behavioral disorder has largely relied on the reductionist on gene 1 disorders approach in which a single gene is necessary and sufficient to develop a disorder. In contrast, a quantitative trait locate approach involves the search for multiple genes. So, what are the types of genetic testing means? Genetic testing can provide information about a person's genes and chromosomes. Available types of testing includes newborn screening. It is used to just after birth to identify genetic disorders that can be treated early in life. Then diagnostic testing. That is, it is used to identify or rule out a specific genetic or chromosomal condition. Then carrier testing. It is used to identify people who carry one copy of gene mutation that, when present in two copies, causes a genetic disorder. That is carrier testing. Then prenatal testing. Prenatal testing is used to detect changes in a fetus's genes or chromosomes before birth. Pre-implantation testing. It is a specialized technique that can reduce the risk of having a child with a particular genetic or chromosomal disorders. So, last one is predictive and pre-symptomatic test. Predictive and pre-symptomatic types of testing are used to detect gene mutations associated with disorders that appear after birth, often later in life. These all are the types mainly we are doing the genetic test. The first one is newborn screening, then diagnostic testing, then carrier testing, then prenatal testing, then pre-implantation testing. The last one is predictive and pre-symptomatic testing. Okay. So next we will see the prenatal diagnosis. First one, how we will do the prenatal diagnosis means we will do the ultrasonography. This is a non-invasive procedure that is harmless to both the fetus and the mother. The developing embryo can first be visualized at about 6 weeks of gestation. Recognition of the major internal organs and extremities to determine if any abnormality can best be accomplished between 16 to 20 weeks of gestation. Okay, this is the procedure for ultrasonography. So, useful in determination of what are the uses? The size and position of the feces, then size and position of the placenta, the amount of amniotic fluid, and the presence of and the appearance of the fetus. This is the main function to analyze the USG ultrasound scan. What are the size of and position of the fetus, the size and position of the placenta, the amount of amniotic fluid, and the appearance of the fetus. So, limitations of USG. What are the limitations? Abnormalities may not be detected until later in pregnancy or may not be detected at all. A good example of this in Down syndrome, trisomy 21, where the morphologic abnormalities are often not marked. Like these children, we cannot identify their abnormalities through the ultrasound scan. For example, Down syndrome. Amniosynthesis. This is an invasive procedure. Amniosynthesis are performed between 14 and 20 weeks of gestation. An ultrasound examination always persists amniosynthesis. In the third trimester of pregnancy, the amniotic fluid can be analyzed for determining of fetal life maturity. Amniotic fluid can be analyzed for lectin, sphygmomyelin ratio, and or for the phosphatidylglycerol. glycerol. What are the risks of amniosynthesis? That means 0.5% of fetal loss, maternal RH sensitization. If oligohydramnios is present means then amniotic fluid cannot be obtained. These all are the risks of amniosynthesis. Then chronic Wiley sampling. What is that? Chronic Wiley sampling is a safely performed between 9.5 and 12.5 weeks of gestation. In this procedure, a catheter is passed via the vagina through the cervix and into the uterus to the developing placenta under ultrasound guidance. The introduction of the catheter allows sampling of cells from the placental chorionic villi. These cells can then be analyzed by variety of techniques. The most common test employed on cells obtained by CVS chorionic villi sampling is chromosome analysis to determine the karyotype of the fetus. This is the chorionic villi sampling. Then maternal blood sampling for fetal cells. This is a new technique that makes use of the phenomena of fetal blood cells gaining access to maternal circulation through the placental villi. The fetal cells can be sorted out and analyzed by a variety of techniques to look for particular DNA sequences. Fluorescence in situ hybridization is one technique that can be applied to identify particular chromosomes of the fetal cells recovered from maternal blood and diagnose aneuploid conditions such as the trisomies and monosomies X. That is maternal blood sampling and fetal cells. What is the problem for that? It is the difficulty to get many fetal blood cells. There may not be enough to reliably determine anomalies of the fetal karyotypes or assay for other abnormalities. Okay. So, next one is maternal serum alpha fetoprotein. That is, the developing fetus has two major blood protein, albumin and alpha fetoprotein. The MSA-FP test can be utilized to determine the level of AFP from the fetus. AFP nothing but not alpha fetoprotein. Ordinarily, only a small amount of alpha fetoprotein gains access to the amniotic fluid and crosses the placenta to mother's blood. This is the test of maternal serum alpha fetoprotein. When there is a neural tube defect in the fetus, then there is a means of escape for more AFP into the amniotic fluid. The AFP from the fetus will ends up in maternal blood in higher amounts. Neutral tube defects include anencephaly and spina bifida. Then the maternal serum beta HCG. This test is most commonly used as a test for pregnancy. The beta HCG can also be quantified in serum from maternal blood, and this can be useful early in pregnancy when threatened abortion or ectopic pregnancy suspected, because the amount of beta HCG will be lower than expected in this condition, threatened abortion and ectopic pregnancy. So we are doing the patient with maternal serum beta HCG test. An elevated beta HCG coupled with a decreased MSA-FP suggests Down syndrome. Very high level of HCG suggests trophoblastic diseases, molar pregnancy. The absence of a fetus on ultrasonography along with an elevated HCG suggests a hydridiform moles. The HCG level can be used to follow up treatment for molar pregnancy to make sure that no trophoblastic disease such as the choriocarcinoma persists. Maternal serum estrol. The amount of estrol in maternal serum is dependent upon a variable fetus, a properly functioning placenta, and maternal well-being. Substrate for estrol being as hydroencephalocitone made by the fetal adrenaline glands. This is further metabolized in the placenta to estrol. The estrol crosses to the maternal circulation and is excreted by the maternal kidney or by the maternal liver in the bile. The measurement of serial estrol levels in the third trimester will give an indication of general well-being of the fetus. If the estrol level drops, then the fetus is threatened and delivery may be necessary emergency. Estrol tends to be lower when Down syndrome is present and when there is adrenal hypoplasia with encephaly. Then inhibin A. Inhibin is secreted by the placenta and the corpus luteum. Inhibin A is associated with an increased risk of trisomy 21. A high inhibin A may associated with a risk of preterm delivery. Then pregnancy associated plasma protein A, PA-PPA. Low level of PA-PPA as measured in maternal serum during the first trimester may be associated with fetal chromosomal anomalies including trisomies 13, 18 and 21. Low PA-PPA levels in the first trimester may predict an adverse pregnancy outcome, including a small for gestational age, baby or stillbirth. A high PA-PPA level may predict a large gestation age, LAGA baby. Triple and quadruple screening, that means combining the maternal serum assays may aid in increasing the sensitivity and specificity of detection of fetal abnormalities. The classic test in the triple screen for alpha fetoprotein, beta HCG and esterol. The quadruple screen adds inhibin A. So, these all are the tests we are doing the patient with genetic testing. What are the testing? Triple or quadruple screening, pregnancy associated plasma protein A, inhibin A, maternal serum esterol, maternal serum beta HCG, maternal serum alpha fetoprotein, then maternal blood sampling for fetal cells, chorionic villus sampling, amniosynthesis, and the last one is ultrasonography. So all are already understood about this test we are doing the patient with genetic testing. So next we will move to the techniques for pathology examination. Cross examination. It is useful in detecting gross fetal parts. The pattern of gross abnormalities can often suggest a possible chromosomal abnormality or a syndrome. Consultation are obtained with clinical geneticists to review the findings. Examination of the placenta is very important because the reason for the fetal loss may be a placental problem. So this is the cross examination. The microscopic examination. Microscopic examination of the placenta is important. Microscopy can aid in determination of gestational age, lungs, kidney maturity. Presence of infection, presence of neoplasia or presence of dysplasia, abnormal organogenesis. So microscopy examination helpful for to find out these all the abnormality or any maturity of the lung and kidney, and the presence of any infection, then presence of neoplasia or the presence of any abnormal organogenesis. These all are the things find out through the microscopic examination. Then radiography. Radiographic views are essential for analysis of the fetal skeleton. Radiographs are useful for comparison with prenatal ultrasound and help determine anomalies when autopsy consent is limited to determine sites to be examined microscopically. So these all are the, if there is the patient have any fetus, if the child, if the fetus have any skeletal abnormalities, means we can analyze this through the radiography. So conditions diagnosed by post-mortem radiography may include skeletal abnormalities, then neural tube defect, that means encephalopathy, then spina bifida, osteogenesis imperfect, then soft tissue changes, hydrops, then hygroma, etc. Then teratomas or other neoplasms, then growth retardation, orientation and audit of fetal parts, assessment of catheter or therapeutic device placement. So these all are the conditions to diagnose the post-mortem radiography should be performed. Microbiological culture. Culture can aid in diagnosis or confirmation of genetic infection. That means TORCH. What is that TORCH means? T means toxoplasmosis, O means other, such as Listeria, monocytogenesis, group B, Streptococcus, syphilis. R means rubella, C means cytomegalovirus, H means herpes simplex or human immunodeficiency virus, that means HIV. Okay. So microbiological culture should be performed for this to identify this type of congenital infections, that means toxoplasmosis, then group B streptococcus syphilis, then rubella, cytomegalovirus, then herpes simplex or human immunodeficiency virus should be assessed through the microbiology culture. Then karyotyping, that means tissue must be obtained as fresh as possible for culture and without contamination. A useful procedure is to wash the tissue samples in sterile saline prior to placing them into cell culture media. Tissues with the best culture of growth are those with the least maceration, placenta, lungs and diaphragm. Obtaining tissue from more than one site can increase the yield by avoiding contamination by detection of the mosaicism, that is karyotyping. Okay. So physical and ethical and legal and psychosocial issues. What are the ethical, legal and psychosocial issues in genetic testing? Consent to being screened. That means patient need to sufficiently inform about the implications of genetic screening before they can provide informed consent. The public view genetic with a sense of inevitability. However, a genetic condition alone may modify the risk for environmental or lifestyle factors. The voluntary nature of the screening process must be emphasized. Then counseling. To reduce potential psychosocial distress, counseling should be available to provide information about genetic risks and explain choices regarding genetic testing and further management. Support is needed for individuals who need to consider issues such as stigma, disclosure to family members and confidentiality. In this condition, we are providing the patients with counseling. Couple known to carry a recessive or dominant single gene defect or sex-linked condition need counseling about their reproductive option. This may include prenatal diagnosis and possibly pregnancy termination in the case of an affected fetus and pre-implantation genetic diagnosis. The risk of stigma. The public's understanding the genetic may be limited and can lead to stigma. Misunderstanding of the genetic risk of developing diseases can increase stigmatization. This may be around life expectancy, lifestyle choices, or decision about having children. Identification of a genetic condition before birth arises issue of whether the parents wish to terminate the pregnancy. Some commentators have argues that the ability to only select perfect babies is a form of ogogenesis. These all are the risk of stigma. Then confidentiality is very important for genetic testing. Like other medical information, results from genetic testing are considered confidential. Under normal practice, the doctor-patient relationship protects against disclosure of genetic information. However, there is less clarity where relatives wish to know the result of family members' genetic test, as it may have direct relevance for them. Another particular dilemma is the case of a pregnant woman wanting to know the result of tests taken by the baby's father. The shortage of genetic screening data and registries of patients creates a particular concern, given that the results may impact negatively on family members. Disclosure to family members. Doctors face a dilemma when reporting the result of genetic testing screening. Standard medical practice is based on the principles that doctors should focus on their patient and that medical information should remain confidential. It is unclear if doctors are ethically permitted to inform relatives in cases when the result of genetic test indicates real risk for their health. Doctors may also be faced with a decision about whether to persuade the patient about the need to disclose their test result to relatives. Although most professional bodies that disclosure should not be against the right of relatives have own priorities. The primary concerns among the public is the use of genetic information to delay access to health insurance or medical treatment. Conversely, health insurance claim right to access such data where it exists to avoid the moral hazards of patients with known condition taking out an insurance policy without disclosing this information. So, these all are the ethical, legal and psychosocial issues of genetic testing. Now we will see the nurses' role in genetic testing. What are the nurses' role? Professional nurses assist individuals in making decisions about DNA studies, ensure that consent is informed before genetic testing, and help clients cope with genetic information after test results are known. Nurses with advanced education in genetic identity and counsel people who are candidates for DNA testing. Hand in hand with action protecting the privacy and confidentiality of patients' information is the role of the nurse in obtaining informed consent for any procedure that requires the collection and analysis of an individual's DNA. Occupational health nurse should be to identify the families who may be at risk to have children with birth defect and genetic disorders. They should be familiar with genetic services available in their community and how to refer families. Nurses safeguard the right to privacy for individuals, families, and communities. The nurse has a duty to maintain confidentiality of all patients' information, both personal and clinical, in the work settings and off duty in all venues, including social media or any other means of communication. Record medical history and symptoms. Collaborate with teams to plan for patient care. Advocate for the health and well-being of the patient. monitoring patient health and record signs, administer medications and treatment, operate medical equipments, perform diagnostic tests, educate patients about management of illness. Genetic nurses perform risk assessment, analyzes the genetic contribution to disease risk, and discuss the impact of risk on healthcare management for individuals and families. They also provide genetic education, provide nursing care to patients and families, and conduct research in genetics. Assessing and planning nursing care procurements, providing pre and post-operation care, monitoring and administering medication and intravenous infusions, taking patient samples, pulses, temperature and blood pressure, writing records, supervising junior staff, organizing work overload.